State University in New Orleans, and I've had some experience in doing translational research. So I'm going to talk to you a little bit about how emergency medicine can do translational research and how we can actually sort of call upon the way that we've developed the field of emergency medicine to develop the field of translational research as well. So I have no disclosures. I'm going to take you back to 1970 to Elliot Friedson, who is a sociologist, or was a sociologist at NYU, and he talked about the whole concept of professionalism and what professionalism is. So one of the things he said is that the fundamental and consistent criterion that distinguishes a profession from just a job or an occupation is its autonomy. And then in an article in 1980, he talked about the emergent role of a new category of workers within the field of medicine called clinical researchers. So when we talk about autonomy in emergency medicine, which is our field, so when our field sort of was in its infancy, a lot of negative things were said, and sometimes still a lot of negative things are said about the fact that emergency medicine physicians are jacks of all trade and masters of none. You know a little bit about a whole lot of things, but you're not really an expert on anything. And to some extent, prior to us having a really autonomous function in emergency medicine, that was to some extent true. We were baby doctors, and we were calling down the anesthesiologist to help us intubate, and the trauma surgeon to manage the stab wound, and the OB doctor to come down and do the precipitous delivery. Early on, when emergency medicine was in its infancy, we were having the experts come and lecture our residents about their content. We were having their articles taught to our residents in Journal Club. And as we started to move out of our infancy and developed autonomy, we started to have our own societies, our own conferences. We started to realize that we really are specialists, right? So we are the experts in the resuscitation and stabilization of every injury and illness known to man. And so we started to establish a unique body of knowledge. And as that came along, we began to have our own journals, you know, some of which are indexed now. And we began to publish articles in other journals that were regarded as landmark articles that we began to have, right? So you look at the Canadian and the New Orleans head CT rules, you look at the early treatment of sepsis, the Manny Rivers articles, you look at pulmonary embolus and the rule out, the PERC rule for pulmonary embolus that came from Jeff Klein, you look at the Ottawa ankle and knee rules, all of the bedside uses of ultrasound that have been developed by us, by emergency physicians, standards for HIV testing, Judd Hollander's standards for managing cocaine chest pain. So we started to have landmark articles in our own field. And along comes this new sexy catchphrase, translational research, because there are fads in medicine just like there are fads in everything else. And so what really is translational research? So translational research aims to make the findings from basic science to have practical applications that enhance the healthcare and the well-being of human beings. And so what's the catchphrase? Bench to bedside, right? So you take the knowledge that's gained at the bench and you use it at the bedside, and your sort of typical prototype of this is the development of different kinds of drugs, specifically cancer treatments. But when you look at that, you know, it's sort of limited. So the people at the bench are going to tell us what we need to do at the bedside, and they're going to know what we need. And a lot of people are not that happy with that whole concept, and so you move to the next level of translational research, and you call it knowledge translation. So the best definition I found of knowledge translation comes from the Canadian Institutes of Health Research, and they talk about the synthesis, dissemination, exchange, and ethically sound application of knowledge. So there's exchange becomes a part of it, meaning that there has to be a back and forth. But the italics are mine. I don't know that the italics are anybody else's. And I don't know that the focus is necessarily on exchange. And really, when you think about it, that's where the focus needs to be. We're still working in silos, where research is one thing, patient care is another, medical education is another, hospital administration is another. What do you do? What's your area of specialty? You know, there's kind of, the twain does not meet in looking at these different areas. And we need to move away from that, because look at what's happened, and I know this slide isn't super legible, but it says healthcare in America. And there's, 2 doctors standing at the bedside, only one is actually touching the patient. And then everybody else in the back, the neurologists, the epidemiologists, the orthopedic surgeons, the cardiothoracic surgeons, the pediatricians, everybody's kind of got an opinion back there, but nobody's really addressing the patient. And translational research has to be bringing knowledge to the patient. The same way that we in emergency medicine took all of the aspects of acute health care and brought them together to take them to the patient, I think that we have to also take all the different kinds of knowledge, break down the silos, and take that to the patient. And we develop, therefore, a more fluid and dynamic model for translational research, where we at the bedside are telling people at the bench what needs to be done. What do we need to know? What works for us? And we're actually starting to see this happen a little bit in terms of having a more fluid and dynamic model where bedside patient care, basic science, medical education, public health, and ED administration are all kind of an endless feedback loop where people in different areas are talking to people in the other areas. One of the things when I started doing translational research, I realized that I went to a meeting in the Department of Cardiology, and they had absolutely no understanding that we did risk stratification of patients in the emergency department when we were looking at who had ACS. Oh, we wish this could be done, and we wish that could be done. Well, it's actually being done, but nobody is talking to each other because basic science is in this building and the emergency department is over in the hospital. So my interpretation of the way to move forward in translational research is to begin to break down the silos. And this is actually starting to happen, and as is typical in not just medicine but all forms of science, it starts to happen and we don't necessarily realize that we're doing it. But we're starting to do it. So how are we in emergency medicine poised to change the face of translational research and make it relevant to our patients? And I'm going to show you some examples of how we're starting to do it and put forth some postulates as to how we might be able to continue to do it. So we've integrated all aspects of other specialties to create our own specialty. We've pioneered uses for emerging technologies like ultrasound, and Tim even talked about some of those that we're using. Our work crosses all borders, right? That's the catchphrase of the book by Dr. Zink. Anyone, anytime, anything, anywhere, we do it. Our work already involves collaboration. We collaborate with consultants, social agencies, governments. We already have global collaborations within our discipline. We have access to the greatest number of patients. That's another thing, my residents will sometimes say, well, we have to call the cardiology fellow, because maybe this patient is having an MI. No. How many MIs has the cardiology fellow diagnosed? And how many MIs has the emergency medicine resident diagnosed? How many PEs has the pulmonology fellow diagnosed? And how many PEs has the emergency medicine resident diagnosed? We're the ones who make the diagnosis, and then we call them and we tell them that they need to admit and take care of the patient. So we have the greatest access to the greatest number of patients in almost any diagnostic category. We know how to take the best of everything and make it work for our patients. And that's what we can do in emergency medicine translational research as well. So let's look at some studies that have actually been done. So here's a French study that I'm going to refer to. So we get a decision tool, or we get a drug, or we get a technique handed down to us by the basic scientists. But does it really work? Is it something that is efficacious for us in emergency medicine when we move to the bedside? And that's the question that was asked by these researchers. This was published in the Annals of Emergency Medicine last year, and it looked at physician gestalt versus decision rules that we are taught to use as the gold standard, and do they work and what works better? So in this study, they had 100 and, I'm getting ahead of myself. Okay, so in this study, the objective was the comparison of physician assessment as low, moderate, or high. as far as the clinical decision rules, the methods, retrospective analysis of a prospective observational cohort of consecutive patients suspected of having PE, and they compared physician Gestalt to Wells and modified Geneva. There were over 1,000 patients in 116 French and 1 Belgian hospital over a 5-week period, and their overall prevalence was 31.3%. Now, mind you, these are patients that the doctor already said, I'm going to rule this patient out for PE. So we're already putting them into the cohort of thinking that they may have a PE, and a third of them did have a PE. But MD Gestalt was better than the revised Geneva and as good as the Wells in the low probability patients, and MD Gestalt was better than the revised Geneva and better than the Wells in the high priority patients. So physicians do a better job at making a decision. So here's a decision rule that's set up as a gold standard. It's handed down to us. We're told to use it. This is the community standard. This is the way we need to do our work. And yet it's been shown that that's not the best way necessarily. That, in fact, we actually know better than some of the decision rules. And so now we have something in the literature as a form of translating what actually is handed down to us as gold standard into what works at the bedside. And now something's published which can make us think again and revise some of the standards. Here's another study. Other people telling us how to manage RED, but do they really know? So can we translate business principles into better management? So this article was also published in Annals in February 2013. And it was a checklist of items that they used for EMS to decide whether a patient could go to a detox unit or needed to come to the hospital. Because what happens in most hospitals throughout the world, EMS finds a drunk laying in the road and they decide that the patient needs to come to the emergency department. Why is that? You know, do they really have a medical need? Is there really something going on that mandates them coming to the emergency department? And yet most of the time, the law enforcement agencies go right along with that. They want the patient brought to the emergency department. But do they need to come? 718 patients were triaged, 20% went to detox, 80% went to the emergency department, and the most common reasons to go to the ED were couldn't walk or couldn't cooperate. Well, those are the reasons we think people need to be in the ED too, right? 58% of those who were sent to the ED actually needed emergency care, but only 0.6% of those sent to detox were later sent to the ED, and every one of those was deemed by the ED physician not to need to go there. So the checklist is actually 99% sensitive and 42% specific, and we're fine with that. We don't mind erring on the side of caution and being a little bit more conservative, but clearly it showed that a lot of patients don't need to come to the emergency department. Patients sent to the ED were over-triaged, but again, that's not necessarily a problem. We don't want to under-triage people. But again, this is sort of a way of taking translation and looking at it in a different way, saying, here's a standard of care that's been handed down to us. Now the bedside is going to give feedback to the bench, or the bedside is going to give feedback to the administration and tell how this is working and whether it really is good for patient care, because certainly it has a negative effect on throughput time and a negative effect on overcrowding. So what else? Translating knowledge from other specialties and applications. Tranexamic acid. This was a large European study on a drug that was actually developed in 1966. It's safe, cheap, and effective, used by our dental colleagues, gynecologists, cardiothoracic surgeons, military physicians. And so in the CRASH-2 study, there was, this took place at 274 hospitals in 40 countries throughout Asia and Europe. There were over 20,000 adult patients enrolled in this study. And the primary outcome was death within 4 weeks. Probably most of you are very, very familiar with this study. But the results showed that early administration of tranexamic acid to trauma patients with or at risk of significant bleeding reduces the risk of death from hemorrhage. There was a lot of controversy about this study for a little while. There was a re-examination of the data. There was a separation of the data for traumatic head injury. But clearly, here we took knowledge that was gained on the battlefield, knowledge that was gained in other specialties, and we translate it into knowledge that could be used in our emergency department. So we're using TXA in our emergency department, and plenty of other places are using it as well because of this study that was done by the CRASH consortium. So what else? We can also take, for translation, some very different sorts of evidence, not just evidence that necessarily comes from other medical fields, but evidence that even comes from business or learning theory. So here's learning theory. This guy, Dr. Tim Elmore, who is an educator who developed the EPIC theory. How do millennials learn? Generation Y, they learn by the EPIC method, experiential, participatory, image-rich, and connected. I actually changed my slide when I heard someone present at this conference because they used the EPIC technique to develop their project that was presented at the conference. And then public health. So for us, in our emergency department, since the index case of HIV in New Orleans in 1981, the case rates among Caucasians have slowly decreased, but the case rates among African Americans have steadily increased. Public health people say, no, we're continuing to educate the public. So what did we do? We did some focus groups, and we found out that the information was not being delivered in a cultural context where it could be heard by the patients and absorbed by them. And so we've changed the cultural context in which it's delivered. And we'll see how that works. But again, this is taking public health principles and applying them. Patients coming into the emergency department with end-stage cancer and a DNR order because the family is afraid to let them die at home. So the nurses become concerned. This also interferes with overcrowding and throughput time. So what do? We start to collaborate between the ED and the hospitalist palliative care service, who then comes down and works with the patient, and there's no need to admit the patient to the hospital. So another form of translation. So how can we change the face of translational research in emergency medicine? First, we can evaluate the work of standard setters. Does it really work for us? We can translate business skills to ED management and administration. We can translate education knowledge to teaching practices. We can translate patient needs to healthcare practices, translate knowledge from other specialties to ours, translate the pressing issues in healthcare back to the basic scientists. Be creative, be collaborative. Because really, if you're wondering about a clinical question, so are other people, and we can all work together. So I see research changes lives by changing practice. And you don't need to be a clinical researcher to necessarily participate in some form of clinical translational research. We can share our questions with each other. If we don't want to do the study, we can give it to someone else. If we want to do the study, we can involve colleagues, because multi-center global data is always more accurate, always more reliable, and always more generalizable, and that's what we as researchers want. Those are the three qualities that make for good research. So as a team, we're making EM a global specialty, and I think that our next challenge is going to be to work together as a team to transform knowledge translation into equitable patient care and medical education on a global scale. So thank you so much for your attention, and if anybody has any questions, I'd be happy to address.